Good day, global citizens. Welcome to another episode of Dr. FAJEMBOLA'S Opinion. On today's episode, I have a senior colleague, a professor, who doesn't want me to use the title professor. Yes, someone who I learned from actively and passively. Actually, I grew more interest in research, although I never told him I grew more interest in research by following him on Twitter and see him share his research publications and discussing on them. So it's an honor to have you on this platform. Please join me to welcome Dr. Abioye.
My pleasure. Thank you very much for the invite.
Thank you so much. Dr. Abioye, we look at, how we do it on this platform, look at tweets first. The first tweet I got on in relation to HIV, in relation to the publication, which is HIV iron levels and anemia, is from Professor Peter Ortiz, where he said, I still remember meeting Dr. Salk in his Salk Institute office in La Jolla, California in 1995, the last year of his life. He gave me advice on our UCOM anemia vaccine, plus shared his ideas for HIV and AIDS vaccine development. We then discussed his wife paintings in his office. Amazing. The second is from a patient herself, Nina Martinez. She said, I said fuck stigma, didn't I? 38 years ago, someone donated blood that fixed my anemia of prematurity. I was born 12 weeks early, 30% chance of survival. And in the longest of odds, I survived, acquiring HIV from that blood. 2.5 years ago, I donated a kidney to another person with HIV. This is the first hand experience of someone with that. Then the last tweet from Bender. Since Fauci is always in the news. Fauci is always in the news. Since Fauci is in the news, this is a good time to remind everyone of Fauci's pet drug, AZT, which is zidovudine, which was failed chemotherapy repurposed to treat HIV. The toxicity of AZT was so extreme, bone marrow suppression and anemia, its benefits so uncertain, and danger so obvious that even the farmer-friendly FDA approved the drug only reluctantly in 1987. The tweet is a bit long, but I just picked the first paragraph.
Yeah.
Yes, so there is a lot of talk on antiretroviral drugs and zidovudine. Dr. Abioye's biography. Dr. Ibraheem Abioye is an accomplished physician, population health scientist, epidemiologist, and biostatistician. He trained as a medical doctor at Lagos State University in Nigeria and holds 3 postgraduate degrees from Harvard University, Masters in Global Health, Biostatistics, and a Ph.D. in Population Health Science. In between, he coordinated clinical trials and prospective cohort studies in Tanzania during a postdoc at Harvard. He also completed a postdoc at Brown University, working on studies set in the Philippines. His Ph.D. thesis and much of his academic research are focused on clarifying the interaction of nutrition, infectious diseases, especially HIV and malaria, and maternal and child health. He co-founded and coordinates StatsClinic, a non-profit organization that delivers free web-based research methods, training to healthcare professionals across African countries. StatsClinic training programs have been attended by thousands of healthcare professionals worldwide. He also teaches epidemiology at Harvard University. He serves as the trial statistician for clinical trials led by the Center for Clinical Trials, Research and Implementation Science at LUT. He is currently a medical director at Genentech, a biotechnology company in California, USA. He leads evidence generation strategy and phase 4 randomized trials for an in-market drug for multiple sclerosis. Dr. Abioye is a highly accomplished researcher with more than 50 publications in high-impact journals. He has led or supported numerous research projects, including projects funded by the U.S. National Institute of Health, Gates Foundation, and the biopharma industry. This is a beautiful biography. Prof, you told me how to use Prof. This is actually excellent, mind-blowing. Well done.
Thank you.
Well done for an academician.
Thank you
Okay,
very much.
Dr. Abioye, let's dive into today's discussion. You have papers actually trying to pick a paper on your work on iron studies. Gave me a bit of tough time, but I just picked one on iron anemia and HIV. And we know that people living with HIV are at high risk of anemia due to their iron intake and to the side effects of antiretroviral drugs, opportunistic infections, and HIV. What sparked your interest? Because you have a span of research publications on iron. What sparked your interest on iron levels?
Thank you very much. So my interest in iron as a research area actually started in 2012. I remember the conversation that I had specifically with Professor Fauzi, who was then the department chair for global health and population at Harvard. And, we were having a conversation and he was telling me about his research, right? So he was telling me about a clinical trial that they were conducting in Tanzania. And this was a trial of iron supplementation on the effect of iron supplementation on placental malaria risk, right?
Okay.
So when he started to tell me about it, I was like, okay, how is this all? I mean, I understand that iron supplementation increases the risk of infections, but I always thought of this I didn't fully understand the scope, right? And I didn't realize it was an active area of research, and so, when we had a conversation about the challenges. So if you think about the fact that iron is related to anemia, right? If you have low iron, then there's going to be a risk of anemia. But if you have too much iron, then you can also increase the risk of infection. And so at these two extremes of iron status, you have two different things. And so how do you carefully find the middle, right? This is really at the center of a lot of iron research, right? Both extremes are unsafe and both extremes are easy to reach. So it's not like there are really wide extremes, So I found the research question fascinating. I also found that it's an area where there was potential to impact lives, right? So if you think about the impact that placental malaria has on pregnancy outcomes, pregnant women go through malaria, and I will say at any point in time in African countries where the malaria is where there's high burden of malaria, you can imagine that there's hundreds of thousands of women who are pregnant at any point in time. And if many of them are at risk of malaria, then think about how the impact potentially cascades if iron supplementation. So the hypothesis was that providing iron supplements increases the risk of malaria. But we need to provide iron supplements because anemia risk is high, right? Pregnant women go through pregnancy, and just by virtue of the pregnancy alone, the risk of iron deficiency increases. So unless you're supplementing the iron, almost every woman is going to end up at the time of delivery, they're going to be anemic, right? So just by natural cause alone. So, but how do we then supplement the iron without increasing the risk of placental malaria, which then has its own adverse consequences? So I found that question fascinating. But I also, when you think about beyond malaria alone, beyond placental malaria, the way that question then cascades onto multiple different, like in the context of HIV, for instance, in the context of TB. So this is a question that continues to be an issue. Anemia risk is high. If you provide iron supplements, you can worsen the infection or increase its risk. So I found that quite interesting. Long-winded way to say that my interest in iron as a research area is partly intellectual. This is a fascinating topic, but also when you think about the potential public health significance of addressing that issue.
Thank you so much, Dr. Abioye, for sharing your story with us. It's quite inspirational. um, what shocked you? I know you have a series of research, as I said earlier. What shocked you most as a researcher on iron levels among African women, especially in Nigeria and Tanzania?
Yeah, I would say that it's the huge burden, right? When we So before I started to work in this space, I kind of knew it on an academic basis that anemia is common, but you don't fully grasp it because you're not thinking about it all the time, right? But if you really think about it, about half of women are at risk of anemia during pregnancy, and almost certainly 1/3 of women will have anemia, right? Unless we're doing something to address it, especially in places where there's a huge risk of malaria, there's a huge risk of other infections, right? And I think the other thing that has increasingly surprised me is that this risk of anemia in pregnancy is not limited to developing countries. Increasingly, we are finding that in high income countries as well, especially among low income families, right? Even in high income countries, you continue to find an elevated risk of anemia as well. So that just the sheer burden, of this is such a huge challenge that we're leaving unaddressed. I think that has surprised me quite a lot.
Okay, thank you so much for that, Dr. Abioye. From the paper, major iron indicators kept resurfacing. What are the major iron indicators?
So, yeah, thanks for asking. And the way that I would think about this is, first of all, when we are talking about iron indicators in the context of clinical practice, the one that first comes to mind is hemoglobin. And hemoglobin concentration is measured throughout pregnancy. It's often available at the bedside. Pretty much every doctor has access to be able to test hemoglobin. And that makes it such an important indicator, right? But in addition to hemoglobin, and I'm going to first of all talk about the biomarkers that are objectively assessed, right? I'm assuming this is the question that you're asking, right? You're asking about how do we determine if a person has iron deficiency. Is that the question? Yeah. Okay. Yeah. So I'm answering the right question. So hemoglobin will be the first one because it's so easily accessible. But the challenge with hemoglobin is that it's not very sensitive. It's not very specific. It tells us about anemia being present, but it doesn't tell us for sure why that person has anemia. And a person could have anemia. There's multiple potential reasons, but the most common is iron deficiency, right? And we want an approach to determine whether a person has iron deficiency that we can trust. And that then leads us to other measures. And the most common measure that's available in full blood count is then MCV, mean corpuscular volume, right? Now, MCV is full blood counts is available also pretty much everywhere. But the reality is that MCV is telling us about the very late stage. So there's a classification that we usually use in understanding iron status measures, right? At the very last end is anemia. And iron deficiency anemia will then be determined as well using MCV. But by the time that is happening in the red blood cells, it's really the impact on the red blood cell is already happened. So if you then go back, we want to be able to assess iron status before the red blood cells are impacted, before hemoglobin levels become low, right? So we want a measure that tells us about the storage of iron itself, and that leads us to something like ferritin. So ferritin concentration, usually measured in serum, but so also sometimes in plasma, then is the other key way that we're assessing iron status. And the WHO now has a classification that is based on ferritin and hemoglobin to be able to define iron deficiency anemia. Now, sometimes because ferritin has has its own weakness, and that weakness is that it's an acute phase reactant. That means that when there's inflammation, whether whether you have enough ferritin levels or not, your ferritin levels will increase. And because ferritin levels are increasing due to inflammation, it makes it hard. We don't know whether if a person is in front of you, if their ferritin is 100, you don't know if their ferritin of 100 really means that they have enough iron, or is it 100 because they also have malaria, or because
Okay.
they also have HIV, or because they have been exposed to some environmental toxicities. So we need better ways. And one of the ways that we then get around that is to also measure a measure of inflammation like C-reactive protein, right? And so if the C-reactive protein level is normal, right, usually we would use something like 5 as the cutoff. If C-reactive protein level is normal and ferritin is high, then we will say that, okay, then this person has enough ferritin. But if C-reactive protein level is high, then we will have some adjustment approaches. But that's really ferritin and CRP to correct it. There are other measures as well. And each of these measures are assessing along the pathway from when iron is stored in the blood, right, like ferritin, or when you start having what we call iron deficient erythropoiesis, right, where iron is already deficient, and now the red blood cell is creating red blood cells are being produced that do not have enough iron, right? So along that pathway, before we then have iron deficiency anemia, which is the last final stage where you're seeing that hemoglobin levels are low, there's some other indicators that we can use to assess along the way. And so you'll have something like zinc protoporphyrin, you have something like soluble transferrin receptor, and there are a number of others as well. But these are all biomarkers. For clinicians, however, if a patient is sitting in front of you, what you most likely be thinking about is the clinical metrics, like is this person pale, right? Do they have symptoms? But the challenge is that anemia is such a non-specific condition that the same symptoms that you will see in other conditions, you could potentially also see in people with anemia. They might be tired and you don't know, are they tired because they're anemic or they're tired because they have malaria, so yeah. But in thinking about indicators that are objective, hemoglobin, ferritin, MCV sometimes are usually the ones that we're thinking the most about.
Thank you so much for discussing that question extensively, Dr. Abioye. You've worked across different age groups. I want to know, is there any difference in prognosis on iron supplementation in children and adults living with HIV?
So HIV is a more challenging topic, and have kind of stayed away from HIV as we've discussed. I've mostly focused on like pregnant women, malaria, because HIV has its own huge other aspect. So the long and short is that we don't really know much as far as HIV is concerned, right? I'll tell you what we know about HIV. We know that anemia is a problem in HIV. We can say with some certainty that HIV patients who have anemia have a much higher risk that they're going to die within the next year. So maybe 3 times higher risk, which is substantial. So we know that. We also know that, that serum ferritin, which is a measure of iron status, along the line, once a person starts taking HIV treatment, that the serum ferritin levels will decline. And we don't know whether this decline in serum ferritin levels, is it happening because their body is using up the iron, or it's happening because as they're getting treated now, the serum ferritin level was high before because of inflammation. I said that it's an acute phase reactant, right? If it was high before because of inflammation and now it's declining, is that just the impact of the antiretroviral therapy? Right. So two things I have said. First is that if the person has anemia, there's a higher risk of death. Second is that once they start antiretroviral therapy, their ferritin levels are dropping, and so we're wondering, are they getting worse in terms of iron deficiency? We don't know for sure, but we know to some degree that if they do have increased risk of iron deficiency and they have anemia, so it's kind of more challenging in that regard. We know that the anemia is bad for them, but we don't know for sure if iron deficiency is bad for them. And there have been some studies where they have actually provided iron supplements to, or let me say it this way. There have been studies where they looked at HIV patients who received iron supplements and they looked at how their impact over time. And they found that it really depends on how severe their anemia is, right? But it does appear that the anemia obviously leads to death if it's unaddressed. But even those who receive iron supplements, there seems to be a high risk of receiving iron supplements, and so that paradoxical situation, it's really hard to disentangle. And so that's why I'm hesitant to be able to say, oh, what's the prognosis of iron supplementation in HIV? The truth is that we don't really know, right? There was a recent trial that was conducted among children that found that children who receive iron supplements did well. The iron supplements helped them. The anemia risk was lower. And because we already know that anemia risk is related to death, although they did not study death because they didn't have enough time to follow up the children, we can expect that because it lowered the risk of anemia, then we can expect lower risk of death. But there has not been any such study among adults. So that leaves us with a huge gap, a huge research gap. And if you give me money today, I will go conduct the study.
Thank you for sharing that perspective, Dr. Abioye. If you want to fund Dr. Abioye's research, you can send me a DM or send me a DM. Okay, Dr. Abioye, let's go to the next question. When anyone mentions anemia, because I see you as an expert when it comes to anemia, iron levels, when anyone mentions anemia, what are the three words that come to your mind?
When a person mentions anemia, I think about iron, right? Because iron deficiency is a big part of anemia. I think about mortality, right? Because that's one of the huge consequences of anemia. But the other thing that I think about is costs. And this is one aspect that most people are not really reflecting on. One thing that we know in terms of the consequence, even if a person is not dying from anemia, is that the cost of their care for whatever other condition that they have just increases. So if a person has anemia, but also has chronic kidney disease, for instance, right, which is usually comorbid, the cost of treating that chronic kidney disease is much higher, right? If a person has HIV and they're anemic, which is also usually comorbid, that anemia increases the cost of care, and that's concerning. So even if we were to be able to address the more severe and there's no death, right, then costs continue to be an issue. Yeah. So these are the three.
Okay, thank you. Okay, thank you for sharing that with us, Dr. Abioye. Actually, the last part, I'm sure cost will be a surprise to people know iron levels and what else cost is often ignored in the discussion for anemia. From the paper, now diving deeper into the paper, from the paper, I quote, therefore, both iron use and anemia were independently associated with increased mortality risk. As a lead author of this publication, what do you want us to take home from this?
What I would like anyone who is listening, to take away from this research body is that we don't really know, right? So we can see that there are challenges, but we haven't been able to fully resolve them. we see that we see that anemia risk is high, anemia is associated with mortality, and anemia is common. But we don't know for sure how to address that anemia. Half of anemia, even in HIV, is due to iron deficiency, or maybe a third, right, is due to HIV. And sorry, is due to an iron deficiency. Half of anemia, even in HIV, is due to iron deficiency. And so if we cannot provide iron supplements, what can we do? Because now we are also seeing that iron supplements are increasing the risk of death. So we need a way. So it's either we're carefully selecting those that we treat with iron supplements, so maybe it's not everybody. So it might be that the people who are dying are not the people who are benefiting. And so disentangling that is essential, so which is an area of work where I think iron research needs to look into in some more detail.
Okay, Dr. Abioye. Again, from the paper, the prevalence of anemia among people living with HIV is as high as 80 to 90% in some settings. What causes the difference in prevalence?
Yeah, so anemia in HIV patients, so that if you think the way that sentence is worded is it could be as high as, right? There's many HIV patients that don't have anemia at all. But those who experience such high anemia burden is usually because their HIV is severe. So people who have the most severe disease, so most advanced HIV disease, are more likely to have anemia as well, right? So that's one of the key factors. But there are other factors as well. So people who have poor nutrition, right, poor socioeconomic status, they are also likely to experience an elevated risk of anemia. And they're likely to be the ones that have the greatest risk. I would say that closely related to advanced disease is opportunistic infections, right? And people who have opportunistic infections are also likely to have anemia. And by the time you take out these groups, so advanced disease, opportunistic infections, poor nutrition, you really address the group of people who are at that really high risk of anemia. And the average HIV patient who is maybe stage 1 HIV might not even be anemic, obviously, because for them to be stage 1, they will not be anemic. But my point is, if their HIV is well controlled and they're well nourished, they might not have an increased anemia risk at all. So yeah.
Okay, thank you, Dr. Abioye, for the excellent answer, for elaborating. I'm also learning. I'm sure our listeners and viewers are learning. You and your team elaborated iron metabolism in the paper. What do you want us, the audience, to hold on to on iron metabolism?
So, okay. So I'll just describe very briefly and say that when a person consumes iron in their diet, so we all consume iron in our diet, whether we like it or not. The question is, what extent of iron are we consuming? And the diet that a person has, if you have diet that is rich in animal source proteins, like meat, red meat especially, then they're likely to be consuming high amounts of iron. Or certain leafy vegetables also are rich in iron. And when you consume iron supplements, like when you consume, or if you're taking iron supplements, right? So the iron in your diet the iron in your diet is absorbed in the small intestines and then absorbed into the blood. I'm just going to give a very quick summary of the metabolism, right? It's absorbed into the blood, and in the red blood cells in the blood, it is transported. It's first in that's where it's also stored in that's where it's stored in ferritin and circulating ferritin. And some of the key issues to bear in mind are how this circulating ferritin is then related to systemic infections, right? Or how it's related to the transfer of iron supplements in pregnancy, or how it's related to systemic infections and transfer of iron supplements in pregnancy. So I will say that some of the I'm not sure how much detail I should be going into, and given that the audience will be coming across this in maybe the first time, I guess a few things to note, and then I'll just stop talking about iron metabolism. One, the source of iron is from our diet, mostly. The second source of iron is from iron that is recycled. So the iron in the red blood cells is also recycled, and that's the second source, right? And the iron that then affects, and then it's stored in ferritin vesicles and carried around, and it's all over the body in many cells. Okay. But the other thing to note is that iron metabolism is that iron is always balanced. The body tries its best to keep the iron levels at a certain range, so that if the iron is potentially going too high, then the body finds ways to take out the excess, and they will usually pass it out in feces. Okay, so there's hepcidin, which is called the master regulator of iron, and hepcidin helps to sort of trigger either reduced absorption, excess excretion of iron, and just to ensure that we are keeping the metabolism in check to some degree. But obviously, we know that there are times when that metabolic pathway becomes overwhelmed and we have excess iron. So there are people who, for whatever reason, genetics, end up having really high levels of iron, partly because the metabolic pathway that's responsible for keeping the ions low is broken. I guess maybe I should stop there. But those are the key things: the source, where it comes from, how it's maintained, and how it then interacts with infections, and yeah.
Thank you for sharing those insightful points with us, Dr. Abioye. In the paper, when I read it, I came across the anemia of inflammation and iron-restricted anemia. Please, can you shed more light on them?
Yeah, so anemia of inflammation, and I have talked about it a little bit, partly. So you remember I said that when a person has systemic inflammation, like in malaria, like in HIV, the ferritin levels go high. Okay? And that's because ferritin is an acute phase reactant. So I did say that. But there are other things that are also happening. And one of the issues that's really happening is that when there is systemic inflammation, the body is trying to reduce the access of, let me back up and say that the most common sources of inflammation that we're talking about in this case are infections. And if you think about, let's use HIV as the paradigm, the HIV virus uses iron in its metabolism. So when the person is infected with HIV, same thing with TB, bacterial infections, when the person is infected with those conditions, one of the ways that the body is trying to protect itself is to keep the iron away from the pathogens. So you don't want the HIV to access the iron. You don't want the bacteria to access the iron. And in trying to keep the iron away from the pathogens, it goes and stores the iron in the spleen, in the lymph nodes, and this sequestration is what it's called of iron. When the iron is sequestered away in this manner, the body then has trouble accessing iron for its own uses. So red blood cell production becomes impacted, and before you know what's happening, there is some form of anemia. Now, this person has high levels of ferritin, which means they should have enough iron, but they also have anemia because their body is not producing enough red blood cells. The body is not having access to the iron. So what's really not happening? What's happening is that there is not enough bioavailable iron for the body to use because the iron is sequestered away in the reticular endothelial system. And so you then have this scenario where there's anemia, and this kind of anemia is what is called anemia of inflammation, could also be called iron-restricted anemia. And it results when a person has systemic inflammation. I hope that's not too much of an explanation.
It's not so much, Dr. Abioye. Thank you for elaborating on both types of anemia. Last question is if you come across, because we come across individuals, but as a researcher on this publication, if you come across an individual who has both HIV and TB, what picture are you expecting on their iron metabolism, and what advice will you give on their hematologic status?
Yeah, good question. Thank you for asking that. I will say that it really depends on how severe the condition is, right? If we're thinking about the person with the most severe form of HIV or the most severe form of TB, or maybe someone who has comorbid HIV and TB, I would likely expect that they will be anemic, right? The question usually then is what kind of anemia? And because unfortunately, these diseases tend to walk hand in hand with poor nutrition, there's a good chance that they're going to have iron deficiency anemia. Okay? But there's also a chance that they might have a somewhat mixed picture, where if you look in the blood film, you will see both red blood cells that look like they're microcytic and hypochromic, which is characteristic of iron deficiency, or you might find red blood cells that are not necessarily meeting that criteria, and you might be thinking maybe this is some form of mixed anemia, all right, where there's anemia of inflammation, but there's also evidence of what looks like iron deficiency. This is also likely to be the picture. But in terms of clinical presentation, right, they'll also be pale. Iron deficiency doesn't really have a different clinical presentation from other forms of anemia. Beyond it becomes different when the iron deficiency is severe and chronic. That's when you start to have all the chorionicea and those other conditions that are classically talked about in medical books. But the reality is that most people who have iron deficiency will not present like that. It's very often just the pallor, that people are presenting with, and so it's hard to see a person and say, oh, maybe this is iron deficiency. Very unlikely. Instead, they will just be pale, they have anemia, and then you will investigate and say, oh, this is likely to be from iron deficiency. And regardless, if a person has HIV and has TB, even if you think they have iron deficiency, you still have to treat the underlying condition, right? Because very often unless you address the HIV, and it's well controlled, unless you address the TB, then you might not be able to address the anemia. Usually you need to address those first, and the anemia of iron deficiency anemia remains unaddressed. Then you start asking yourself, how do I fix this? If it's too severe, then you might consider transfusion. Or if it's not too severe, you're wondering, is there a role for iron supplementation here? But I'm waiting for you to send me the money for that trial so that, we can study it.
Okay, thank you, Dr. Abioye, for painting a detailed picture for us. Do you have a closing statement? Everything looks simple and summarized because you are an expert. Thank you so much. Please give us a closing statement.
No, thank you. Thank you very much for inviting me. I haven't gotten to talk about iron deficiency in a while. So it's always great to talk about it. This is a topic that I'm really passionate about. I have spent a considerable amount of time doing research on iron. So I said 2012 was when I first became excited, and then I started working on clinical trial on iron supplements. This is an area of research where there's a lot that has been done. That means that if you come into research in iron, there's a lot of materials. They're not going to be groping in the dark, right? There's a lot that's already fully fleshed out. But there's also key gaps that are addressable, So I will say that if there are people who are interested in doing research, this is an area where it makes sense to spend time. But the other thing that I would say is also good in iron is it's a space where you can easily learn a lot of different methods, right? So animal studies, just the whole gamut of potential research in biological sciences can be applied in the context of iron supplements. There's interaction of iron supplements with drugs, the interaction of iron supplements with other micronutrients. There's a lot of open research questions. So I would encourage anyone who is interested in helping us to address these questions to definitely sign up for research here.
Okay, thank you so much once again, Dr. Abioye. Global citizens, Dr. Abioye has discussed iron level, HIV, and anemia extensively for us. He has wide range of publications on iron levels. Do read his papers. We shared his paper, one of his papers on iron levels and anemia on our weekly read. So please do read his paper, absorb the needed information, share with colleagues, discuss with colleagues, and most importantly, use it for yourself. Have a blessed week, everyone.
Thank you very much.